Hi guys, I hope you had an awesome weekend. This is week 8, which means we're just crossing the middle of the semester, which is exciting, right? I will start by giving you some feedback, and then we'll talk about chapter 10. And before I forget anything else, I want to say 2 things. Advising. If I'm your advisor or I mean, you have another advisor, please connect with them. As far as I'm concerned, you should have received a link to take you to a Google Word document where you can pick a spot so we can visit next week, right? So it's coming up. Have your plans ready, know your holds, and so on and so forth. If you are my advisee and you haven't received that link for the shared document, let me know. But I'm 99.9% sure that I've sent it to everybody. Okay, last week actually. All right, now because they moved advising and the whole schedule changed a little bit, I had to move our third synchronous meeting from next week to this week. So this week, this Wednesday, we have a synchronous meeting at 8 in the morning. Okay, different time for so I'm trying to be a little bit more fair to other people. So I wanted to make sure that that's clear. Office hours, as always, on Tuesdays from 8 to 12:30. But Wednesday we have 45-minute synchronous meeting, so we can visit, and I can also give you extra credit, right? So that's it. Concerning feedback, LO 91%, really good. But there was one item that most of you missed, and it was talking about the calipers, and about the base of the fold or in the middle of the fold. So try to figure that out. It's really important to know where you put the calipers, okay? LO 20, 80%, nothing really to address here, and LO 21, 93%. So as you may be guessing, the lowest score, the lowest average is for an LO that has to do with the GETP book, the 10th edition. For this Sunday, LO 22, 23, 24, okay? And yeah, I talked about advising and about the synchronous meeting. So we're gonna just go ahead and I'm gonna share my screen and I'm gonna go to a Moodle site just to make sure we're good. So here we are, right? So chapter 10 I'm covering today. These are for Sunday, and there's a synchronous meeting at 8, I think so, right? Yes, at 8. And you get 10 extra points. Again, non-mandatory. I just want to visit, and you know how it is. Okay. All right. So we have chapter 10, a long chapter, a lot of information. I would say 2/5 of that chapter is about diabetes mellitus. So we're going to spend some time there, and also have hypertension, dyslipidemia, what else? Bariatric surgery at the very end. So a lot of stuff for today. It's gonna be fun though, don't worry about it. We'll take it little by little and I'll explain everything. All right, here we go. Metabolic disease and cardiovascular risk factors. Okay, so a group of metabolic diseases that are characterized by blood glucose concentration elevated, which is called hyperglycemia. You know that. As a result of defects in insulin secretion, so we don't have enough, and or inability to use it, okay? And that's the main characteristic of identifying between type 2 and type 1. Yes, remember? Okay, so if we no matter what's the ideology behind it, the elevated blood glucose levels put the patient at risk. And that's what really matters here. Microvascular, macrovascular, so more generalized, right, systemic, as well as neuropathies. Okay, neuropathy has to do with the what? Nervous system, right? 1 out of 10, 28% out of those are not diagnosed, okay, which is interesting. 4 types: type 1 that you know, type 2 that you, type 1 is that you don't, you cannot use insulin, right? Type 2, you cannot produce insulin. Type 3 has to do with what? Pregnancy, right? And 4, everything else. Most of them, most of the diabetics are what? Type 2, yes? Okay. All right, I need to go a little bit faster. Autoimmune destruction of insulin producing beta cells, because at our pancreas, that's where we can produce insulin, right? Why do we care? Insulin does what? We can take glucose to the cells, right? So whether in type 1 situation is there's an inefficiency. So we can, the insulin that we have or that we don't have is not being delivered correctly either. Primary characteristics: insulin deficiency in high tendency for ketoacidosis. So when you cannot break down carbs, you're going to turn into fat. That will create a lot of ketones. But we're talking about a very large amount of ketones. So we're talking about a situation that it is, what's the word I'm looking for? I can't find it right now, but I will. So that it's really high elevated. It messes up with our pH, and it's toxic. That's the word. Toxic environment. It's very toxic, right? Type 2 diabetes: insulin-resistant skeletal muscle, adipose tissue, and liver combined with an insulin secretory defect. So you know about that. Prediabetes is the condition that you have elevated blood glucose, that's impaired glucose tolerance, IGT, and or elevated blood glucose in the fasting state. So either or, it can be both. So you have that elevated blood glucose whether you ate carbs or not. You are in prediabetes. And of course, if you are in prediabetes, you're a very good candidate for diabetes. So you have to be really careful. Glycemic control, exercise, medication, okay? Glycosylated hemoglobin, that's something I want you to know. HbA1c, that's something that when you go and do your blood work, you can even require it from your doctor, right? And it shows your blood glucose levels for the past 2-3 months. You don't have to be fasted for that, okay? So that's one way to figure out what's going on with your blood glucose. These are some things that you need to know. What's normal, not really necessarily need to know, but all of them. But you see there are different ways to do it. We have the HbA1c, right? Which in normal has to be lower than 5.7. Okay, and also you see 3 categories: normal, prediabetes, and diabetes mellitus. So another thing that you see here is fasting plasma glucose. Has to do with fasting, right? 2-hour PG. 2-hour PG is the plasma glucose. That's another, a different blood test. Okay, you don't really need to remember all these numbers. It would be nice if you could remember the 5.7 for normal, for HbA1c, and the FPG less than 100. That's about it. And that we have 3 pretty much tests. Okay, so in that 2-hour PG, they give you something, and 2 hours later, they want to see where your glucose at and how it goes down. That's really important. Okay. Of course, a lot of benefits. I'm not going to even read all this. In any way you see it is beneficial for a diabetic. light to moderate. Here concerning exercise testing, and you'll see that throughout this chapter. If we're talking about light to moderate and we have asymptomatic individuals, usually the exercise testing is not necessary. Okay. Okay, silent ischemia is ischemia that you don't have the symptoms. I hope you remember. Okay, in non-diabetic has all right. Yes, of course. So we can use insulin better by exercising. For those with type 1, it doesn't really work like that, but may lower that exogenous insulin, which means that comes from the outside, which means it's injected, right? Endogenous and exogenous. Okay. There is no evidence that resistance exercise differs from aerobics. So either or, you just need to move. That's really important for you to remember. And there is some evidence that if you combine, it's kind of better. This is what we have here. I would say the only thing that is kind of interesting and what I need to point out is that aerobic column, when you go to time, there's a specific difference based on type. So that's a little bit interesting. Other than that, nothing that we wouldn't expect. If you have diabetes, you may have other things as well. So we need to be careful, and we may need to test for those as well. They may be overweight. We're going to talk about obesity and being overweight in a little bit tonight. So again, if you have multiple conditions, as you understand, it's getting more complicated. In general, if you have several conditions, you go with the one that needs to be, you go with the treatment that is the most safe in a way. You're trying to play it safe differently, and this, like, whatever is the lightest based on each condition, that's usually the one that you would start from, right? So if one condition says 20 minutes of cardio, the other one says 30, you'll start with 20 if I have both. That's what I'm trying to say. It can be very short intervals, so that could work too. Vigorous intensity if we can. Even heat, as you can see, that's really cool, right? Resistance training should be encouraged. Right here we have resistance training should be encouraged, okay. Or pre-diabetes. So we may have contraindications. Uncontrolled hypertension, that's bad. Proliferative retinopathy with the eyes, right? And there we have a new vessel formation. This is for diabetics. So it can threaten your vision at some point by causing retinal detachment. So that's a serious situation, or some kind of hemorrhage in your eye. So we need to take that into consideration. Higher resistance may be beneficial. Yeah, and that's about it. From this one, start slow and keep going up. Nothing too fancy here. During combined training, completing resistance training prior to aerobic training may lower the risk of hypoglycemia. Hypoglycemia is an issue in general here. I don't know if you have ever worked or trained somebody who is diabetic, but it's interesting. Okay, it is really interesting, and it needs to be we need to have specific knowledge, and that's why we're going here today. Flexibility, yes, great, sure, but it doesn't really do anything to diabetes. Okay, so indirectly, yeah, okay, will help because you will be able probably to do more aerobic or anaerobic exercise, but it doesn't really affect insulin. Hypoglycemia, very low glucose levels in our body, right? So if you're taking insulin, insulin will make you use glucose, right? So it takes or you take a hypoglycemic agent that increases insulin secretion, which means again that you will use more glucose. If you use more glucose and then you try to work out, guess what's going to happen? You're going to decrease your levels of glucose even more. That's why here we have to be really careful with hypoglycemia. We may lower it a little bit too much. That's not good. Okay. So we need to be able to identify what is going on, us if we're diabetics, and the person who is next to us and working with us, or the trainer. If you go with the partner, just the person who's working with you needs to be aware. If you are a trainer, you need to be aware of what's going on. Hypoglycemia awareness is you can actually know as a diabetic what would happen if you were hypoglycemic, and you know the symptoms, so you know what's going on, and then you can do something about it. Okay, you see anxiety, tingling, nervousness, sweating, abnormal, all this. And then you have the neuroglycopenic. So you have really low glucose, and that affects your nervous system. And the symptoms you see: headache, visual disturbances, mental dullness, confusion, amnesia, seizures, and even coma. Okay. So if you know this, it will be great. So you have some awareness of what's going on. Exercise timing. As you can see at the bottom, early morning exercise in particular may result in elevations in blood glucose levels instead of the usual decrease with motor activity. That's interesting, isn't it? Okay. Most insulin users will need to consume carbohydrates before. Okay. So you kind of check before, and you have some kind of meal prep before, and you also have food with you in case you go into some kind of hypoglycemic shock, right? Now, if you're taking insulin that's rapid acting, there's more danger of going into hypoglycemia than the slow ones, okay? Hypoglycemia risk is higher during and immediately following exercise, but can occur up to 12 hours. That's also interesting. And that has to do with the education of the trainer and the trainee. Sulfonylurea drugs. So these drugs make us secrete more insulin. Okay, and more insulin means more use of glucose, which again may affect the levels of glucose, which can be really low, so hypoglycemia. Prior to planned exercise, rapid or short-acting insulin, as I said, I will likely have to be reduced to prevent hypoglycemia. And here, if you have longer acting, that's better. Diabetics, type 1 diabetics, they have those pumps usually on them, right? So sometimes they have to fix that as they're working out. They are, of course, following orders from their doctors. So they have better delivery rates. Of course, it has to be monitored. Okay. If it has happened before, you should train with a partner, obviously. Autonomic neuropathy, we'll talk about it in a little bit. I think it's right here too, so let me see. So if you have, that's what I was trying to figure out. Yes, so I put it over here. So we talked about having that hypoglycemia awareness. So you are able to see the symptoms and do something about it before you go into a hypoglycemic shock. Okay. Now, if you have autonomic neuropathy, that has to do with your autonomic nervous system, right? Long duration type 1 diabetes, recent additional hypoglycemia, or exercise contribute to impaired epinephrine and other hormonal responses that really messes up your awareness. So you need to be careful. And since if you cannot be aware of what is going on, you need a test. So you have to monitor it more frequently. That's what I'm trying to say. Polyuria means you pee a lot, right? That acetone breath is really important if you're hyperglycemic, right? Acetone breath. That's classic. And you see there's some numbers here. You don't have to remember them, and you cannot really expect anybody to be able to figure out the level of ketones in the body. Okay, well, we did talked about that it can if we have really high levels of ketones, that's really bad. Okay. Okay. Glucagon, I'm just throwing out there, the so-called, most catabolic hormone. Look it up if you don't know what it is. Compromised thermoregulatory response. So hydration is a thing with diabetics. Cold and hot environments need to be taken into consideration. Retinopathy. Okay. Okay. During exercise, autonomic neuropathy may cause chronotropic incompetence, attenuated VO2 kinetics, and anhidrosis. Hydro, water, right? So there's no water. That's what it means. Proper feet care, if we have peripheral neuropathy, mainly on the feet, right? Special socks, special shoes, dryness. Nephropathy, not neuropathy, nephropathy right now. Nephro is the kidney in Greek, okay? So nephropathy means kidney disease. So take that into consideration as well. All right, so we're done with diabetes. Let's go to dyslipidemia. Abnormal amount of lipids. So we have the LDL, which we want it low. So if it's high, it's bad. We'll have the triglycerides, we want them low. If they're high, it's bad. We'll have HDL, which we want it high. And if it's low, it's bad. Good? Good. All right. 30%, 1 out of 3 have dyslipidemia. And what's the thing with dyslipidemia? Buildup of plaque and atherosclerotic cardiovascular disease. Okay? Okay. Now, many causes. Poor dietary lifestyle choices and or genetics. And it says there, however, genetics often play a prominent contributing role, and very high levels of cholesterol often cluster within families. Okay? Both pure familial hypercholesterolemia. Okay? So hyperlipidemia is the umbrella. Hyperlipidemia can be hypercholesterolemia, it can be hypertriglyceridemia, and it can also be hyperlipidemia. Okay, so here we have usually hypercholesterolemia, which is high cholesterol, LDL, and the combined hyperlipidemia is high LDL and high triglycerides. That's what it is. That's what I was trying to say. Okay. Yeah. Lifestyle changes. Okay. Okay. Statins. So many people are taking statins. I'm not going to talk about if that's a good thing or a bad thing, but it's a thing. Okay. Unfortunately, a lot of people take statins and they don't do all these lifestyle changes, but that's another thing for another conversation. The thing is that when you're taking statins, you may have some issues that we're going to see in a little bit. No exercise testing for asymptomatic patients again. Special considerations here, you have more conditions. Obviously, nothing new here. These are the feed recommendations, and in general, we're talking about the feed, right? Not the VP. We don't have enough evidence to go into V and P. This is the feed principle. Nothing too fancy here. Let me know if you have any questions. Guidelines for all the adults, okay. 10 minutes may be enough, but go to 30 to 60 minutes. Cool. If you take statins, those are the side effects now. You may have pain on your muscles, right? And you lose muscle actually, okay? They also may affect your heart. So, side note in general, it is recommended if you take statins to consider taking Q10. Hypertension. All right, chronic primary hypertension. Well, primary hypertension when hypertension is the thing. You have secondary hypertension, so it's hypertension that happens because you have something else. Okay, so what's hypertension? SBP 140 or more, higher, DBP 90 or higher, or a combination of both. Okay, and you need to be, this needs to be confirmed by a minimum of 2 measures taken on at least 2 separate days, or taking anti-hypertensive medication. So if you're taking medication for blood pressure, that means you have hypertension, right? So yeah. Primary hypertension accounts for 95 of all cases, as you can see. The known contributors of primary hypertension include genetic and lifestyle factors. Now, for the rest, 5%, you see here CKD, chronic kidney disease. Pheochromocytoma is when you have pretty much cancer on your adrenal gland. Excessive aldosterone secretion. Aldosterone is a hormone, peptide hormone. And sleep apnea, almost 80 million, above 20 or above, and 1 billion all over the world. We've said a lot of times it's called the silent killer because a lot of times it goes undiagnosed, right? Part of treatment is DASH, dietary, misspelled over here, approaches to stop hypertension diet. And here we have a nice table. You see the compelling indication means you may have something else with it, pretty much for this, simplified. And so we have with and without. If you're normal, just encourage lifestyle. So normal is below 120, not 120, below 120, below 80. And, see that? And here is or, okay? Okay. So if you are in pre-hypertension, yes, of course, encourage lifestyle modification. You need lifestyle modification, actually. And then if you have another condition, so yes, you are taking something for that other condition. If you have a stage 1 hypertension, you take something for the condition and something for your hypertension. And then here you take 2 or more drugs, right, for hypertension. Stage 1, of course, is better than stage 2. If you are in stage 2 or with target organ disease, may not engage in any exercise, okay? The doctor will tell you what's up. That's it. And if you do, you have to be medically supervised, of course, anyway. Beta blockers have to be taken into consideration because we're taking them so heart rate is lower and the blood pressure is lower. So we need to take that into consideration. Diuretic therapy may experience hypokalemia, electrolyte imbalances. That's not good, right? We've talked about that. These are the FIT principles for somebody who's hypertensive. Nothing really you can understand by yourselves. It is prudent to maintain SBP below 220 and DBP below 105. Okay. Better is moderate intensity safer, although vigorous intensity, of course, may produce more benefits. So it really depends. If they're obese and overweight, which is a lot of times the case, a focus on caloric deficit is a thing. Inhaling and breath holding, again, is a thing, of course, because it increases blood pressure. Why would you prescribe or suggest Valsalva maneuver when I'm already hypertensive? Okay. Thermoregulatory function, so that's important. We'll have to take that into consideration. Non-selective beta blockers. So I'm just giving you a little bit of information that you may not be able to find. So beta blockers can hit the beta 1, beta 2, beta 3 receptors. The non-selective ones just go for all of them, but sometimes we take beta blockers for just something specific like beta 2, okay? Okay. So the BP lowering effects of aerobic exercise are immediate. So that's a post-exercise hypotension. We should really be interested in that and looking for that. That's really important. Okay. All right. So let's go now to something which is even more serious, right? Let me sip some coffee. So just a second. So, sorry. So metabolic syndrome, medicine. Okay. A cluster of risk factors, so a lot, that are associated with increased incidence of CVD, DM, and stroke. Okay, it is very serious if you have metabolic syndrome. Very, very serious. The defining criteria, I want you to know that, of medicine includes hyperglycemia or taking meds for that, which is the same. Elevated blood pressure or taking meds for hypertension. Dyslipidemia or taking statins, for example. And national or regional cut points for central adiposity, right, around our middle section, based on waist circumference. So if you have at least 3 of those factors, you have medicine. Excuse me, hyperglycemia, high blood pressure, dyslipidemia, the cut points for, excuse me again, central adiposity, okay? The thing here is that, and I'm gonna increase that a little bit, is that the main organizations have agreed on the number and on the specific risk factors, but not on the cutoff points. So you'll see some difference. So we have the International Diabetes Foundation, World Health Organization, and the National Cholesterol Education Program over there, but you see they are a little bit different. Okay. For example, WHO even has albumin. Okay, it has to do with urea. So it's a little bit different. In general, though, you have 3 out of those we just mentioned, you have medicine, and this is very, very serious. International Diabetes Foundation guidelines moderate restriction in energy intake to achieve a 5 to 10% weight loss within a year, moderate increase in physical activity, change in dietary intake. Nothing that we wouldn't expect, right? Particular consideration for dyslipidemia, hypertension, or hyperglycemia when present. Okay. Low excess capacity may be a thing. High blood pressure may be another thing. They're difficult clients, very complicated situations. There's so many things going on, so many variables. You don't even know where you're gonna, where to look first. It's messy. But that's why we're doing this, at least to have a better understanding of what we know. We don't know everything, obviously. We need more data. So attention. So when you are designing that exercise prescription, attention should be given to each risk factor condition present with the most conservative criteria. So we need the most conservative criteria. Again, something I used before. So if we're talking about vigorous intensity for one condition, moderate intensity for another condition, you're going to go with moderate. It's 5 sets and 3 sets. You're going to go with 3 sets. It's 5 days per week and 3 days per week. You'll go for 3 days per week. Okay. So most likely that's the way you're going to go. Okay. Reduction of body weight is important, obviously. Resistance training, when combined with aerobic training, can produce greater decreases in medicine prevalence than that of aerobic training alone. So that's good. And now we're moving to overweight and obesity. Okay, so overweight, 25 to 29.9, 30 or greater, that's obese. You should know that. Okay, 2 out of 3 Americans adults are overweight. 1/3 is obese, and 6% is extremely obese, above 40. Wow. Okay, so also we have the pediatric obesity, which is huge, 32%. Now, why do we care? Because they're linked to numerous chronic diseases. That's why we care. That's it. 7% of total healthcare costs. Loss of 3 to 5% will have some clinically meaningful reduction. So we see some kind of benefit if we lose 3 to 5% of body weight. That's great, right? Okay, so combination, of course. PA appears to have a modest impact on the magnitude of weight loss observed across the initial weight loss intervention compared with reductions in energy intake. So energy intake, in simple words, energy intake appears to be more impactful when compared to PA. So the diet part is more important than the physical activity part. Combinations, yes, sure, better, yeah, okay. Now, those pose a relationship, which means, of course, that more of something will have more benefits, right? So more cardio, for example. Exercise test is not necessarily, it's not necessary. Other comorbidities, so we need to be careful again. Medication, you need to be careful again. Other condition, musculoskeletal, orthopedic, again. Start slow. Weight specification is another thing. So you want to use a treadmill or bike or something, they have to, first of all, feet. And second of all, the weight has to be, the machine has to be able to carry that weight. Appropriate calf size, again, when you're taking blood pressure. Nothing too fancy here, moderate intensity, as you can see, and then if they can go to vigorous, that would be great. Progress to more minutes per week. Okay. Now, this is kind of important. I want you to remember, okay? Resistance training does not result in clinically significant weight loss. The addition of resistance exercise to energy restriction does not appear to prevent the loss of fat-free mass or the observed reduction in resting energy expenditure. Okay, so it looks like cardio is more important. We should be focusing on cardio when we have obese clients, whether we like it or not. That's what the data says. So we have, so in terms of weight loss and fat-free mass, okay, they're going to be stronger. They may be a little bit more stable. Yes, sure. But remember that, please. Okay. 1,500 calories per day may be a thing, but that's very aggressive. So whatever the doctor says, sure. Communication with everybody who is affected and can help in a way. Now, of course, target changing behaviors, because if you change the behavior, everything else will change, right? If you change the habit, then as I say, no, I'm not saying that, other people say it, but I've said it in class, habit changes you. So if you change the behavior, that behavior will change you. Now, if you cannot, for whatever reasons, you can't change your diet, or you don't change your diet, you can't change your lifestyle, or you don't change your lifestyle, you may need to move into something that is way more drastic, like a bariatric surgery. I don't know, probably you've heard about gastric bypass, right? So very invasive, but something needs to be done. And you see what kind of people would be appropriate for this kind of action. BMI 40 or above, comorbidity risk factors, BMI 30 or above. Okay. So again, I don't know if you know, people very invasive, takes time to heal. You have to change your lifestyle. You have to change the way you eat after all this. A lot of people, unfortunately, in the long run, return to their old habits, thinking that now that I've done the surgery, I'm gonna eat whatever I want. That's wrong. We need education for the patients. We need education for the significant others in the family. It's something big. Bariatric surgery is no joke. Okay. All right. So that was it. Kept it at 1 hour. It wasn't bad at all. What I want to say is office hours tomorrow from 8 to 12:30. Synchronous meeting on Wednesday at 8, from 8 to 8:45. LOs 22 to 24, and this was chapter 10. So hope to see you guys this week.